We'll start. We usually have a few people trickle in here as we go. When it comes to summertime, we expect a little bit of a different attendance than before. So we've been really lucky here. We've had about 30 people more show up to these presentations, which I really appreciate. It's had some great questions. But with this, I expect maybe not so many people, which means we get to have a lot more interaction. And the other great thing today is we have Dr. Krychek from Digestive Health Clinic here today. And he is a GI physician and will definitely be able to give a lot of great information and some good highlights as to some of the things we'll discuss. Most of the things we'll talk about here in colorectal cancer will come from a value-based healthcare perspective today. And I think that's a great way of looking at things. Not only is it part and parcel of almost all of our quality contracts, but I think it's something that we all agree this needs to be done. Now, the question is, how are we being graded on it? It's not always as clear as you'd think. So for anyone who doesn't know, I'm Dr. Michael Toomey. I'm a physician family medicine here in Boise, and I have been with the St. Alphonsus Health Alliance as their medical director for over a year now. So excited to be here with you. Your mute button may not work, so you may not be able to actually speak and ask your question. So please put it in the chat, and either I will catch it or someone will be able to inform you that it's there, and let us know. Thank you. As always, we start with a reflection. So this one, running away from any problem only increases the distance from the solution. The easiest way to escape from the problem is to solve it. And we don't know who said that. Our objectives today, we're going to understand our quality measures for colorectal cancer screening. We want to understand who and why are people being excluded. What are our coding requirements and our documentation requirements? Our Pearl strategies and takeaways for our meeting measures, and of course our network resources that you should be aware of. So why should we screen for colorectal cancer? It's kind of a no-brainer, but just as a review, it claims over 50,000 lives yearly, and it's the third most common cause of cancer for both men and women. It's one of our deadliest cancers, but you can also treat it really easily if you catch it early. And that's all a part of screening and catching it before it kind of grows into a stage 3 or 4 tumor. When we talk about CRC deaths, they are decreasing for older Americans, but on the flip side, they're really increasing and fairly rapidly for our younger cohort. And that's in part why we need to be screening people at younger ages and how that change from 50 to 45 has occurred. We're seeing them even at younger areas, and that's a difficult thing to deal with when you see someone in their 30s with colon cancer, and you just wish that you could have intervened earlier, but you didn't know that they were at risk. So definitely something that we've heard a lot of scary stories about, but fortunately not the majority. Majority are still older, but that risk does seem to be increasing for our younger aged members. When we talk about our elderly population and when we stop screening, really at 75, that's when the recommendations are we don't have to screen. That group between 76 and 85, we still can, and it should be an individual decision based, of course, on longevity, health, and what's going on. So someone with a strong family history of colorectal cancer, but also a strong longevity history, definitely someone who you might want to screen there in their late 70s. And we really shouldn't be screening people once they're 85 and older. Again, individual decisions, but when you think about colonoscopies, they also incur risk. And as you get older and older, there's a higher risk of perforation, which certainly can happen. So what are our DE&I considerations? Certainly there is some racial disparities when it comes to colorectal cancer screening, and it does disproportionately affect our Black communities. They are 20% more likely to get colorectal cancer and 40% more likely to die from it. We think that this is mostly due to socioeconomic status and social influences of health instead of more genetic factors, but I don't think it's fully fleshed out at this point. When we talk about screenings and who is more likely to get colorectal cancer, that is really folded into who has previously gotten the screening in the past. Because when you get a screening with a colonoscopy, you're able to remove polyps that could grow into cancer over time. And so Just because someone is more likely to get it doesn't mean that they are genetically more likely to get it if they didn't have the prior screenings before to help kind of keep things under control. Your risk factors, we always try to break those into modifiable and non-modifiable. Our modifiable ones, those are big issues when it comes to obesity and sedentary life. That does create kind of inflammatory pathways that definitely increase a lot of cancers, but colorectal cancer especially. Diets high in red meat. When we look nationally across different countries, we kind of see different countries having much higher or lower risks of colorectal cancer. And we do think that that's in part because of the processed meats that we have in our diet. And if you go to Japan, they do not have nearly as high of a risk of colorectal cancer. Instead, they have a higher risk of gastric cancers based on their diets. And that holds true if you take an American and move them to Japan and have them eat a Japanese diet, or a Japanese person and move them to America and have them eat an American diet. Tobacco use and alcohol use, certainly risk factors as well. Your non-modifiable, again, age, as you get older, that risk does increase over time. We're talking about inflammatory bowel disease, adenomatous polyps, personal history, family history, and some of the rare polyposis disorders that, of course, occur. Now, let's think about it from an insurance perspective. How are we graded and why? So that denominator, the amount of patients that they're looking at in total, it's going to be the percentage of patients that are between 45 and 75 years of age. And they're looking to see who among them have had appropriate screening for colorectal cancer. And the ways that you can screen are quite a few. You can have the FOBT test, the FIT test, the FIT DNA, and that you can just substitute the word Cologuard for that, right? But there are many other ways that are being developed that use a DNA and that FIT test as well for it. CT colonography, sigmoidoscopy, and a colonoscopy. So lots of different options here for people, and we'll, of course, talk in more detail about each of those. Who can be excluded from this? Really, anyone who's had colon cancer at any time before the current year. And then a total colectomy, of course, before the current year. They're going to exclude those if you are on hospice or palliative care or you died. So good reasons to not be currently getting a colonoscopy. In addition, if you are older than 66, or if you're 66 and older, and you have an advanced illness and frailty that are coded during the year, you will not be counted as part of this cohort that needs to get a colonoscopy. And this can be difficult for us providers to remember and understand. And so I would just highlight that this is possible. And if you have someone who is sick and you know is sick but is young, right, is going to be younger than 75 when they stop measuring this is when you need your help of your coders. And you say, hey, this person is ill. I don't want them in any of these value-based care quality metrics. Can you help me make sure that I'm getting the coding correct so that this happens? Now, the official exclusions and how you do this, you need the advanced illness documented in 2 outpatient charts or 1 inpatient chart. And there's a couple other ways of doing it, like if you had a dementia medication. So that's kind of the easiest way. I actually like that one because our dementia patients, once they get the medication of memantine or donepezil, that excludes them as long as you get the frailty on the back end. But this can be face-to-face or telehealth. And really the diagnoses are pretty sick. So it's usually a cancer diagnosis, dementia, Parkinson's, Alzheimer's, heart failure. Emphysema counts, but straight up COPD does not. ESRD as well. And then once you have that diagnosis, you also have to have a frailty code. And this is where we kind of get missed. And that frailty code is often like falls or at risk for falls or fatigue. There's a whole host and long list that I'm happy to get you if you're interested. But again, this is where we use our coders, right? But that code is the one that gets missed, not the advanced disease one. If you have a serious advanced disease in this patient, like cirrhosis or heart failure, you're going to be documenting it where the specialist is. Another way you can get a frailty documentation would be a walker, cane, or wheelchair order. And that will go through based on the DME order that's placed. So you don't have to worry about coding it in that case. But again, ask me, ask a coder. what are our documentation requirements? This is actually interesting because I was kind of misinformed before I did this, and it was great to kind of understand what counts and what doesn't. Of course, if we get the screening in there in our chart, that counts. So that would be like the colonoscopy report, right? You get the procedure report from the provider, you get that in your chart, it's documented with a date, that counts. Good. You don't actually have to have the pathology report, even though, of course, I want you to get it if you're a PCP. That's important. And just the pathology report actually counts. You can say that you have proof that they did a colonoscopy at that time. However, if the pathology report isn't super clear that it was actually a full colonoscopy and the patient doesn't actually know, you probably have to code it as a sigmoidoscopy, which means that you have to redo it in 5 years. So important to kind of have that full picture of, did our colonoscopist get all the way to the end and look at the cecum? Because that can be a high point where people can certainly get cancers from. Now, patient-reported data is also eligible. So that's kind of different from some of our other qualities. If you go into the health maintenance in Epic and you say, I know this person had a colonoscopy on March 15th of 2023. They told me that. They assert it. I just can't find the records from California. It's gone. I don't know where it is. If you put that in with a date discussing that it was a colonoscopy and you have it in the medical record, it counts. And that's kind of nice. So certainly make sure your staff gathers that information, but know that there's not necessarily you're not committing fraud by putting the date that the patient says it was done on. That's helpful. One thing that you should be aware of is when we're looking at Cologuard specifically, we tend to have these messages that come through our charts when that says, hey, we sent the Cologuard, but there wasn't enough stool, or there was an issue and we can't process it. And that message will be from Cologuard, and Epic will translate that as, whoops, we actually have a check mark based on the colorectal cancer screening. And you and I know that they weren't actually screened. They couldn't actually get that test done. So we do have to mark that as an unsuccessful screening. Either you or your staff should mark that so it doesn't flow into the health maintenance. So just a helpful tip there. Now, what happens when they decline a colonoscopy or they can't get it done before the end of the year, so you're not going to get credit for it? What do we do? And the great news is we have a couple options. And now I think we have had so many lunch meals from Cologuard, and we've had a lot of ads. And I think it's great to kind of dig into, hey, what's behind this? Let's make sure we're talking about the data behind this too. I want you, of course, to include any risk benefits and alternatives in your discussion in your chart notes. And, when you are marking this, make sure that if the patient actually declines and doesn't want anything, don't just discontinue the recommendation, postpone it for the next year and keep having that conversation. And let's talk about our alternatives. So we usually are doing either a FIT test or a FIT DNA. And that's in part because the FOBT tests are kind of limited in some ways. So you really need 3 different FOBT tests in order to test. That's a fecal occult blood test, right? And you shouldn't be having any red meat around that time. You shouldn't be using aspirin or any NSAIDs. And so there's definitely limitations there that aren't present with the FIT test. And our FIT test is an immunochemical test, so you don't have to change the diet. Actually not recommended to stop your NSAIDs or aspirin, even though theoretically it could make some changes there. It's a cheap test and it should be done yearly, right? It's very easy for the patient to do. This doesn't have some of the requirements that Cologuard does, or FIT DNA, right? And the sample size is obviously a lot smaller. So, Dr. Krychek, I'll have you jump in here a little bit. Can you talk to me about what and who has recommended tier 1 versus tier 2 tests?
Yeah. First of all, thanks for having me. Second, I don't know if I'm as dynamic a speaker as you, so I apologize to our audience for that. The Historically, the USPSTF and the more general societies have not differentiated on tiers for screening. They have said the best screening test is the screening test that gets done, and that's very hard logic to argue with. The Multi-Services Task Force, which is made up of the GI societies, has said that FIT testing, not FIT DNA, and colonoscopy are tier one test, and then that Cologuard or Fit Fecal DNA fits into tier two. Obviously, the GI societies may have a bias because it's made up of a group of colonoscopists. So questioning that decision is reasonable, but it is made on good data. More interestingly, 2022, the American College of Physicians came out with a guideline for colorectal cancer screening, and their recommendation was to not, definitively not use fit fecal DNA as a screening test for colon cancer. That was based on some of the testing characteristics as well as the cost of the study when you compare it to FIT testing, which performs as good or better for a significantly lower cost. But that I was surprised by that American College of Physicians statement. Again, I think that's from I think it's 2022 when they came out with their guideline. I can speak more to it if you like, but I think that's kind of the highlights when it comes to specifically Cologuard.
Yeah, I'll kind of paint a little bit more of a picture, and I'll have you jump in after a second here. I think one important reason why that's the case is because of cost. And so our fit tests are $24 each, right? And if you're thinking about a 10-year screening pathway, 240 bucks is pretty cheap, assuming you don't have a positive that requires you to go then to a colonoscopy. In fact, the Cologuard test or a fit DNA could be the most expensive test. Now, if you had a colonoscopy that ended up having some polyp removals, or you had a colonoscopy in the hospital, it's going to be higher than that $1,000. And certainly they can vary depending on what hospital you're going to and what procedure is being done exactly. But again, having that in mind, with you're doing 3 tests, Cologuard could be the most expensive. In addition, theoretically, if you are able to get that fit test every single year, you're going to have basically improved sensitivity and specificity, or at least equivalent when it comes to your Cologuard. Now, they both have struggles when it comes to catching adenomatous polyps, right? And so you might have a 40% rate of capture when it comes to Cologuard with an advanced adenoma. And those advanced adenomas really do need to be treated with colonoscopy. So there's a big benefit to getting that scope in, getting visualization and removal of that polyp. But if you're only doing it once and you have that patient who struggles to get in, struggles to do and follow up on their testing, yeah, you're going to have some reduced sensitivity in comparison to a one-time Cologuard test, right? So I think that is the hemming and hawing that some PCPs do. In addition, we often don't have a structure around, let me call that person to make sure they get that fit test done. Let me call that person to make sure they know exactly what to do and that they're coming in and they're doing all of this. That's value-based healthcare 101, but we don't have as many resources for that. Cologuard doesn't get paid to do their test until that test is done and in their mailbox and it's run and processed. And so they have a whole team of people that are really motivated to make sure that they get that 500 to 600 bucks. And they're calling the patient and trying to get them to put it in the mail. So I think the support around them is beneficial to PCPs. But again, why can't we just have that support for our fit tests and do this on a regular basis? That would be a nicer situation, I think. Any other highlights, Dr. Krychek, that I missed there, or discussions about the adenomatous polyps?
No, I think you're spot on. You're exactly right. And this is a little bit educational for me with regards to how much documentation goes into this test not being done or not being done. I think Cologuard has done a very nice job of making that part of it easier for you guys. As you said, colonoscopy should accomplish the same thing. As you refer to an outside provider, of making sure that documentation is done and having someone else kind of tapping that patient on the shoulder and asking them to come in. But that is where Cologuard shines. The infrastructure they've built around their test really is hard to compete with. What needs to happen is there needs to be programs, and this happens very well in European countries where there's broad-based programs around fit testing that do a lot of what Cologuard does. We don't really have that in America. It would be nice if we did, because as you said, I think from a value-based perspective, I think it's a really good test.
Yeah. And then what happens when it's a positive Cologuard and we get a negative colonoscopy? What are you thinking about when that happens?
Well, the gastroenterologist or whoever does the colonoscopy gets a little less sleep because it is a good test. But it is important to know that the New England Journal of Medicine article that came out in 2014, which basically is how fit fecal DNA got its approval, found a 45% negative colonoscopy rate. So if you are going to recommend Cologuard, I think it's prudent to have a short discussion about the fact that if there's a positive test, it means you have a 4% chance of having a cancer and a 45% chance of having a normal colonoscopy. My big gripe with Cologuard is these patients come into our office with convinced that they have cancer, and they're very, very frightened when I think that amount of anxiety is unnecessary based on the testing characteristics. But to answer your question directly, if they have a negative Cologuard, they go back into routine screening every 10 years. And if the test is positive for a non-cancerous lesion, their recall is based on that lesion, not the positive Cologuard test.
Thanks. All right. So tips, we went over all this. Make sure that we've abstracted the screening. We got lots of people to help you with that if you need assistance. Our fit DNA results that can't be processed, mark as unsuccessful. And again, don't discontinue colorectal cancer screening because you still got to get done. It's your job to try to convince them the next year, right? Just postpone. All right. These are some helpful codes. Most of the time, you're going to use the encounters for screening for malignant neoplasm of colon cancer, and that's your generic ordering for colonoscopy or for a Cologuard or for a FIT test or for an FOBT. Palliative care and hospice E&M codes, those are going to be dropped by the palliative and hospice groups. So I think we're good there. Now, other things to be aware of is if you're 66 and older and you have an institutional special needs plan, so those are usually our kind of dual eligible Medicare, Medicaid patients, or you're in a long-term care facility for more than 90 days, then, most of the time you don't need to have a colonoscopy either. So those patients would be excluded as well. So if you are rounding on someone who's a chronic long-term care facility patient, we don't have to stress about this. We're okay. One important thing when it comes to understanding HCC codes, so these are the codes that comprise of risk adjustment factors, right? Primary malignancy is always a hotbed of discussion. And part of the issue is because we have medications that sometimes will keep people from getting the cancer. We have chemos, we got radiation, and it's hard to know when I need to be coding colon cancer or history of colon cancer. So the official rules are that if you have been diagnosed with colon cancer or any cancer, right, and are ongoing with treatment, so that means surgery, radiation or chemotherapy, or you've got still residual cancer there, you can code colorectal cancer and any other codes that might occur. But once it's been eradicated and you don't have further evidence that there is a tumor there, we need to code a personal history of malignancy. That includes if the patient is on Lupron or tamoxifen, or if they had breast cancer and they're on anastrozole or something like that. Those are very common medications that might be on for many years after the cancer. And once that's done, assuming the CT scan shows no residual cancers, personal history of malignancy, we should not be getting credit for active cancer patient on our ranks, basically, because that would code a much higher risk of the patient for them. The other thing to be aware of is that when someone's on chemotherapy or on one of these medications, it does affect their immune system. And so making sure that you're thinking about coding for immunodeficiencies due to medications or due to any other specific disease, that will help your RAF score, your risk adjusted score be more accurate. Don't forget about that. Ask your coder if you need help. Strategies for help. I think we kind of went over all of this. Don't have anything additional, but it's a good review of all the things that we've talked about today. Who is our in-network providers? We've got the Digestive Health Clinic. Thank you, Dr. Krychek, for being here, giving some color to our discussion. We've got St. Alphonsus Medical Group. We have general surgeons, and we have family medicine providers, depending on where you are, that do colonoscopies. West Valley Medical Group also has some specialty services, and Valor Health General Surgery will do some colonoscopies as well. Those are the main ones, but certainly they can discuss any details if you'd like. We certainly have a full list of all of our in-network providers available on our website for people. And would love to address any questions here. We got some good resources for today. I see Kathy in the chat has asked, Do you have a current action plan to educate our SAMG providers with this information? Helpful for working these quality measures in the CRC measure. So I am happy to educate anyone and everyone who would like to. This is open to all SAMG providers as well, and it is recorded, so we are happy to push that out. We have a lot of SAMG providers, if you haven't noticed. So it's difficult to reach all of them at all times, but I'm happy to do this again in any capacity. The way you can support that is saying, hey, I learned a lot here today. Would love to help push this out. How can we get it to happen? And we'll see what we can do. Anything else, Dr. Krychek, that we missed today or that we should talk about? Thank you again for your input. Really appreciate it today.
Well, I appreciate you having me. There were just a couple things that have come out recently that I think are topical that might come up in patient discussions. Um, One thing when it comes to talking to patients about screening, there's been a lot of research around how to increase screening adherence, and they found that the probably the most effective way is a sequential approach where you offer a colonoscopy. You state that this is both a diagnostic and therapeutic test if it comes to adenomatous polyps, and it has the longest recall. And if they are not interested in that, picking one or maybe two other tests to talk to them about, and that would probably be a FIT and a Cologuard, rather than providing them with a bunch of options that has had a significantly lower um, adherence rate. But I think the thing that's probably coming up more recently for people is one, there's the blood-based screening test that has gotten a lot of mention in the lay press. And what we found is that that has an 83% sensitivity for CRC, and a 13% sensitivity for advanced lesions. Number one, it's not covered by the FDA if your patients ask you about it. Number two, it has pretty good testing characteristics for a blood test, but it doesn't meet the standard of a FIT test, fecal DNA, or a colonoscopy, and it's not ready for prime time screening. The use of this may be something that's used in very young people, just because of the really frightening increase in young colon cancers, which has been noted both in the data and anecdotally. The other thing that's coming out that's interesting, and I think we'll see in the next round of guidelines for colonoscopy, is that it looks like a negative colonoscopy is protective for not only 10 years, but probably up to 15. And so I think the next round, or within the next decade at least, the colonoscopy recall is going to go from 10 years to 15 years. Now, that's me reading the tea leaves. That's not necessarily based on any guidelines at this point, but the data continues to suggest that the protection of colonoscopy is very, very strong. And so hopefully in the future, when we're talking to patients about colonoscopy, the idea that if they have a negative test, they may not need another one for an even longer period of time, will increase interest and adherence to doing the test.
That's great to hear. Yeah.
Yeah. Otherwise, thank you guys for having me. I really appreciate it. This is a great forum. And as was said before, if this is something that people are interested in hearing more about, us at Digestive Health Clinic and me in particular would be happy to talk to whomever's willing to listen to me. Okay. I got a 2 and a 5-year-old who won't, so I got to find somebody to listen to me. Thanks,
you
guys.
and I both. I think we got similar age kids then.
Yeah. Okay.
Our next visit here will be in August 15th, Thursday morning again, and we'll talk about hypertension and medication adherence during that time. We're going to hopefully have one of our pharmacists help participate in that conversation and have a good, robust discussion. So looking forward to seeing you guys then. Thank you all for your time today. Have a wonderful day.